Hi, everyone. We're going to get started now. Thank you for joining us today for this important webinar titled Understanding and Bolstering the Peer Recovery Workforce. And this is a webinar that's going to be reporting on work that FORE has commissioned looking at the peer recovery workforce and really looking at what is going to be needed to really expand this workforce to address the opioid crisis into the future. Just quickly, we would like to acknowledge SSRS, the survey firm who helped with this project. And to begin, I'm just gonna do our normal spiel that we do at the beginning of every webinar, which is go over the logistics of it, how you can ask questions, as well as a little background on the foundation. So let's begin. My name is Ken Shaskis. I'm the Senior Program Officer here at FORE. I'd like to remind everyone that the findings from the study can be found on our website, forefdn.org, where you'll be able to find not only the full report from today, but also an issue brief going over, giving a little bit of more of a summary of the report and what we see as important. You'll also be able to check out a grantee spotlight that goes over, that is interviewing 3 peer recovery coaches at 3 of our 4 grantee organizations. And we would highly encourage you to check those out. Very impactful piece. Let's continue on quickly with some webinar logistics. As with all of our webinars, this is being recorded and you'll be able to find it on our website pretty much an hour or so after the session ends, and that will include also the presentation slides made available. For questions, we will be having a Q&A at the end for our panelists for about 15 to 20 minutes. If you'd like to ask a question throughout, you can actually use the Q&A box that you'll find at the bottom of the screen to submit your question. We would check to see, we would ask you to check to look at all the questions that have been submitted already. Because if there's a similar question, we'd ask you to upvote it. So we make sure that we are answering the most pressing questions that people want to hear, and we'll be able to prioritize in that order. And we will answer as many as time permits. However, we will provide a Q&A document with questions that we do not have time to address. It will be posted on our website as well. Lastly, there'll be a brief survey immediately following the webinar, which is an important one this time, as that's going to help inform our next programmatic activities and help us frame the larger survey around peers that FORE is planning to do later this year. So please fill out that survey. Great. So now, a little bit about the foundation. FORE was founded in 2018. We're a 501c3 private national grant-making foundation focused on the opioid crisis. Our vision is to inspire and accelerate action to end the crisis. And our mission is to convene and support partners that are advancing patient-centered, evidence-based solutions, specifically addressing the opioid crisis. Now, everything we do, patients are at our center. And all of our work falls into a framework of 4 focus areas: professional education, payer and provider strategies, policy initiatives, as well as public awareness. So now FORE has been around now for, I know we were created in 2018, probably doing real programmatic work for about 2 years now. And happy to say that we've been able to really build out a really nice program around these 3 different areas listed here, all complementing each other. So grant making, you can see our RFPs and our grants on our website. I'll make a plug to say that we do have one RFP open right now, the Opioid Crisis Innovation Challenge. Would highly encourage you to take a look at it and see if it's something you'd be interested in. And applications for that RFP are due at midnight on this Monday, actually. We also work to convene partners and stakeholders in this area to learn from them and to help inform where our programs are headed. And we develop resources and thought leadership. You can always go to our website and see a number of our resources, policy briefs, issue briefs, reports, past webinars, all accessible through there. And with that, I would like to introduce the president of our foundation, Dr. Karen Scott, who will help lead the activities today. So with that, I'm gonna ask Karen to start her video. Unmute.
Yep.
Great.
Great. Thank you, Ken. There we go. Thanks so much, Ken. And welcome, I want to welcome all of our presenters today, who I will introduce as we go along, and to all of you joining us in the audience today. Last summer, as we began to support several projects focused on recovery supports in response to the pandemic, we saw how frequently peer recovery coaches were proposed as key components of the work. In addition to that, several of the first projects we'd funded on access to treatment also included peers. This led to significant discussion within the foundation about what we could be doing to better understand and support this part of the workforce. And this in turn led to wanting to hear more and learn more from peers themselves as an important first step before we went into more programmatic funding. So over the last several months, we have worked with Robin Rappaport, Rob Manley, and Aubrey Kaufman at the survey firm SSRS, as well as a national project advisory group to develop this project. Phase 1, which is the focus of the discussion and the findings today, is a qualitative study engaging a diverse group of peer recovery coaches from around the country. The findings in and of themselves are very powerful, we think, but the findings will also help inform the second phase of the project, which we are planning as a large multi-state survey later this year. We very much look forward to the discussion that this work can help generate in terms of strengthening this workforce. But before we get to the findings, I'm very pleased to welcome our first guest to the webinar today, and Tom Coderre. Tom is Acting Deputy Assistant Secretary for Mental Health and Substance Use at SAMHSA, the Substance Abuse and Mental Health Services Administration. Mr. Coderre is highly regarded as a leader in the addiction and recovery space, and of course, most recently served as Acting Assistant Secretary for Mental Health and Substance Use in the first few months of the Biden-Harris administration. Tom, thank you so much for joining us today.
Thank you so much, Dr. Scott, and good afternoon, everyone. It's really a pleasure to have been invited by FORE to be part of this webinar today and to talk about SAMHSA's efforts to build the peer recovery workforce. I'm honored to be joined by several dear friends and colleagues on the program today. You know, I know this isn't going to come as a surprise to you, but recovery is not a robust area of science. And so whenever something like this gets released, I get really excited, or whenever one of Dr. Kelly's studies gets released, I get really excited because I think this is so important. And I understand that I'm the only thing that stands in the way of why you're all here today is to learn about the findings from the important study. So I'll try to be brief. While I may be the Acting Deputy Assistant Secretary for Mental Health and Substance Use at SAMHSA, more importantly for today's conversation, I'm a person in long-term recovery, which for me means I haven't used alcohol or drugs since May 15th of 2003. And I've been able to create a better life for myself, for my family, and ultimately my entire community, because that's what happens when people find and sustain their recovery. Everything around them changes. Make no mistake about it, I was a badly broken human being 18 years ago. And my road through treatment to recovery, it's been long and it's been winding. But even with the services I was fortunate to receive, maybe some would even say privileged to receive, no one waved a magic wand and all of a sudden I instantly became well. It happened over time, not overnight. And it happened because I had support. I know many who may be joining today understand the hard work required to successfully complete treatment and sustain recovery, and that you know that peer support plays a vital role in this process. For me personally, peer support was essential for my recovery. Peer support taught me that I was not alone. Peer support taught me that treatment's effective and that people do recover. Peer support gave me hope, community, a belief in today and a faith in tomorrow. Peer support provided a resilient and robust infrastructure of people and places, and peer support provided a loving but rigorous cohort of reinforcers, people who understood the pitfalls, the daily struggles, the doubts, the uncertainties, and the rationalizations, and who, passing no judgment, did not waver in pointing the way forward for me. These peers are also people that a power much greater than myself brought into my life to give meaning and purpose to my life and to set me on a path where I now have the ability to help others in need. Peer recovery coaches work alongside individuals seeking recovery from substance use disorders. They're there to help people create their own customized recovery plans, building on individual strengths, needs, and recovery goals, which lead them onto their own recovery pathways. The support provided may be emotional by displaying empathy and concern, informational by connecting people to information and referrals to community resources that support health and wellness, tangible, providing concrete support such as housing or employment, and affiliation support by establishing connections to recovery community supports, activities, and events. Peer recovery support can be provided prior to, during, and or after treatment. SAMHSA's work in building the peer workforce began more than 2 decades ago with the first Recovery Community Services Program grants, what we call RCSP. And while the process for some of us has seemed painfully slow, every single year we've added resources and programs to build upon the previous. And the Biden-Harris administration is going even further to support recovery. The administration's statement of drug policy priorities included advancing recovery-friendly workplaces, expanding the workforce, and expanding access to recovery support services as key tenets. That's the first time that's happened in a drug policy report. We've also seen historic funding for the full continuum of prevention, intervention, treatment, and recovery support. Earlier this year, the president signed the American Rescue Plan into law, which appropriated $3.5 billion to expand access to vital behavioral health services, including recovery support. President Biden's FY22 budget requests an additional $1.65 billion for the Substance Abuse Prevention and Treatment Block Grant, and includes a 10% set aside for recovery support services. This new set aside will allow us to continue to invest in the peer recovery workforce and the infrastructure required to support it. I'm thrilled to see this proposal moving through the appropriations process in Congress. SAMHSA believes that peer recovery specialists and coaches are instrumental in recovery work. It's imperative that we continue to provide training and support to empower and educate peers in the workforce. In 2020, SAMHSA created the Peer Recovery Center of Excellence at the University of Missouri, Kansas City. The center is led by a steering committee of national peer recovery leaders who provide training and technical assistance related to recovery. The Peer Recovery Center of Excellence is a resource to individuals, organizations, and systems working to advance the successful implementation of the peer support model of recovery in various settings. The Center of Excellence builds on the work that Bringing Recovery Supports to Scale Technical Assistance Center did before its sunset in 2019. SAMHSA has several recovery-oriented grant portfolios supporting nonprofit entities that provide peer recovery services. These programs have been instrumental in offering support to help individuals achieve and maintain recovery. Now I'd like to highlight some of SAMHSA's major initiatives focused on peer recovery services. The first one is the State Opioid Response Grant Program, or the SORE grant program as we commonly refer to it. It's SAMHSA's foremost initiative focused on opioid use disorder. With SORE funds, states are required to implement service delivery models that enable a full spectrum of treatment and recovery support services that facilitate positive treatment outcomes and long-term recovery. Recovery support services are delivered by peers and recovery coaches to help individuals achieve stable recovery. Thus far, the program has provided over 10,000 recovery coaching services, almost 18,000 peer coaching or mentoring services, and nearly 5,000 employment coaching services. Some outstanding activities in the workforce through the SOAR program include the California Emergency Department Bridge Project, which supports the use of peers as substance use navigators who work within hospital settings to improve access to treatment. They assist with access to social support and health services. The Safe Station program in Maryland, and I know these exist in other parts of the country, in New Hampshire and Rhode Island come to mind. They provide care coordination, peer recovery support, and legal assistance with warrant resolution. Entry and admission to Safe Stations is the beginning of a process that includes a team to assist individuals with opioid addiction to help remove barriers and to connect individuals to treatment. The second program is SAMHSA's Building Communities of Recovery, or BCOR initiative, which mobilizes resources within and outside the recovery community to increase the prevalence and quality of long-term recovery support. These grants are intended to support the development, enhancement, expansion, and delivery of recovery support services and the promotion of and education about recovery. Currently, there are 75 B Corp grants around the country. 31 of them were recently awarded. B Corp provides direct services and support services that include peer recovery support services designed and delivered by people who have lived experience. These services embody a powerful message of hope, as well as a wealth of experiential knowledge. It's important to note that activities are designed to reduce discrimination or negative attitudes concerning people with addiction in recovery from drug and alcohol addiction. One B Corp grant recipient in Florida matches peer recovery support services with clients who are using medication to assist them in their recovery journey. They connect participants with prescribing physicians who work hand in hand with peer recovery specialists. Overall, they incorporate client monitoring, resource referral, care management, support groups, medication monitoring, and mentoring to provide the most comprehensive services to ensure maintaining compliance and to build recovery capital. The Recovery Community Services Program is the next program I wanted to talk about, RCSP, I mentioned it earlier. Those grants are still around and they provide peer recovery support services via recovery community organizations to individuals with substance use disorders, co-occurring substance use and mental health disorders, or those in recovery from these disorders. Like the other recovery-oriented portfolios, the RCSP program is based on the value of lived experience of peers to assist others in achieving and maintaining recovery. A Texas RCSP grantee recipient places methadone clients in recovery housing for 45 days. They receive peer recovery coaching support services. In addition, they also receive meals, educational groups, relapse prevention, spirituality, arts and crafts. They get transported to 12-step and other recovery meetings, family groups, and referral to outside sources. And the last program that I wanted to mention today is the longstanding Targeted Capacity Expansion Peer-to-Peer program, which expands and enhances service capacity through the provision of peer recovery support services for individuals with substance use disorders and their family members. Again, those with lived experience play an integral role in designing, developing, and implementing these programs. A peer-to-peer grant recipient in New York is a peer-led, peer-governed, and has a history of promoting and utilizing peer workforce to engage and support individuals facing substance use, including individuals on medication-assisted treatment. The peer recovery coaches co-facilitate peer mentoring circles and are responsible for social media messaging. They are also involved with the advisory board and advocacy. Another initiative, the medication-assisted treatment prescription drug opioid program, expands and enhances access to medication-assisted treatment services for persons with opioid use disorder seeking or receiving medication-assisted treatment. Primary outcomes are to increase the number of individuals with opioid use disorder receiving medication-assisted treatment and decrease illicit opioid drug use and prescription opioid misuse. Recovery support services are designed to improve access to and retention in treatment and facilitate long-term recovery as a required activity. One grant recipient remarked that a recovery coach has been a peer recovery specialist for the past 2.5 years. She's a statewide speaker who advocates and promotes peer recovery coaching and facilitates 2 telehealth support groups weekly. In addition, she assists patients with transportation, develops wellness plans, and is a mentor for other coaches. Another project director noted that they were grateful that peer recovery support was a part of the grant. Our peer recovery support specialist was able to bring information to the program and help the program meet milestones. You must treat that specialist like they are part of the team and are vital to the program. We could not have survived this pandemic without our peer specialists. The last initiative I want to highlight is SAMHSA's innovative workforce support program to implement evidence-based programs and support individuals in treatment and recovery to live independently and participate in the workforce. The staff of the Pennsylvania Workforce Support Program are all in recovery. Staff coordinate peer-based recovery support service strategies and interventions, including face-to-face support sessions, telehealth, and social media support. A workforce support employer remarked, "Your program provides a purpose to these individuals that will go forth with a transferable skill. We tell clients that there will be times when the difficult choice is to stay on this path. It should not be lost on anyone that programs such as yours and our industry are well suited to work together for a different reason, but the same outcome." I'm a firm believer in second chances. I'm grateful that you chose to help people realize a dream, and I'm honored for our company to be part of a community that does just that. So as you can see, SAMHSA and our grant recipients alike understand the importance and value our peer recovery specialists and our recovery coaches in meeting the needs of everyone seeking recovery. The flexibility and ability of agencies to provide support and training that leads to certification for peer recovery coaches, that's life-changing. Isolation from COVID-19 has resulted in peer recovery specialists leaving an indelible mark on recovery programs across the country. Peer recovery specialists have been the lifeline for individuals with opioid use disorder seeking recovery. They are true American heroes. Thank you for highlighting them today. Let's continue to grow their numbers and their impact on our country. Thank you.
Tom, thank you so much for those remarks. So powerful for you to start off by demonstrating how clearly and impactful peers were in your own life and your own trajectory in recovery. And then thank you for giving us the landscape in terms of the types of programs and opportunities there are for engaging with peers right now. I hope that we can continue to be a resource and partner with you as we continue to learn about and develop this workforce. I also hope you get to take a look at some of the comments in the chat, Tom, because there are many people there who are very grateful for your work and leadership. And to that end, I understand that 10% set aside for recovery services is very much the result of your leadership. So thank you.
Thank you. It's my pleasure. And I really look forward to working with everybody going forward. We've got lots of work to do, so let's get it done.
Great. Thank you so much, Tom.
Thank you.
Great. So now we will turn to hearing about some of the findings from the study. And I am joined by Aubrey Kaufman, who's a moderator and research analyst at SSRS. And Aubrey is going to lead off on telling us about the methodology and some of the key findings from the survey. Aubrey.
Thank you so much, Karen. And man, it's tough to follow Tom, isn't it? But I found that our study was really important. I might be biased, but I think that our findings were really, really interesting. So as Karen mentioned, I was the moderator and the analyst on this study. I am also a licensed clinician. I work in a trauma-informed space and have a background in substance use disorder. So it was a real personal and professional privilege to be a part of this research. We can go ahead and move on to the next slide. A little about the research before we dive into all the findings. As many of you know, peer recovery coaches we don't have a ton of information about their roles. It's still an area of the workforce that we could certainly do more to learn more about. We really aimed to understand what their challenges are, what their career trajectory looks like, how COVID has impacted things for them. All the way back to the very beginning with what drove and motivated them to become peer recovery coaches in the first place. And so all the findings that you are going to hear about were through that lens with the intent of just learning more about all of the nuances and details of the work that they do, from the joys to the challenges, and of course, identifying any opportunities for support along the way. FORE also plans to use this information that was collected from the qualitative phase to inform a larger quantitative portion. So we'll get a little bit more into that towards the very end. Great, so a little about the methodology. There were actually 2 phases within this first phase. So again, these findings are all going to be from the qualitative portion of the study, which is what we've done so far. And this research took place between March 8th and May 13th of this year. A total of 47 PRCs, or peer recovery coaches, were involved in this portion of the research. Phase 1 consisted of an online bulletin board, which was a really great opportunity to start to lay that framework for the certification journey. We wanted to take it again from the very beginning, what motivated these individuals to become peer recovery coaches in the first place, all the way through the education and certification requirements that it took to get there, the career trajectory, what their workforce experiences had been like, all the way till now, the time of COVID. And so the online bulletin board allowed us to really start to understand that that journey and inform the next phase, phase 2, which was our IDIs. These were in-depth interviews that were conducted over webcam with 20 PRCs, and 4 of those were participants from the online bulletin board as well, which gave us a really rich insight. Some of them had participated in both phases and some were brand new, stepping in just at the IDI portion. So we were able to explore themes that arose in the online bulletin board a little deeper at that point. Again, and I'll probably mention this a couple times throughout reporting these findings, but these findings are qualitative in nature. So I certainly want to encourage everyone to use the lens that they are meant to be viewed directionally. It gives us rich insights, though they are certainly not intended for extrapolation. The sample sizes are smaller with this research. And so hopefully that is what we will be able to use the quantitative findings for at a later time. And I would certainly need to thank all of the peer recovery coaches that took part in this study. They were speaking about personal experiences as well as their professional experiences. And I was deeply moved by how open they were and thankful they were to participate in this research, which I think tells us a lot about how much research needs to be done throughout this space. We can go ahead and move on to the next slide. So starting with the very beginning, the motivations for becoming a peer recovery coach. We heard a couple things here. One was that serving as a peer recovery coach gives participants a clear sense of purpose. Many were sharing, I should note here that all that we spoke with had their own lived experience with recovery. And so many of them shared that coming out of a recovery space, they weren't sure what their futures looked like, especially from a workforce lens. They weren't sure where they were going to go with this background. And so having the opportunity to move into a peer recovery space gave them a really clear, kind of definitive sense of what they could do with this experience that they had just had. Furthermore, many were already volunteering in this space or doing something in the recovery space before they decided to become a peer recovery coach. So again, some were volunteering and some were working in paid positions, but in more administrative roles in a recovery space. Once they learned, as many of them were not aware that this was an option, that they could become certified, it added a layer of legitimacy to the work that they did, that they were already doing, some for free, and provided them an opportunity to move into a paid role for, again, what they were already doing professionally. In the interest of time, I won't read the verbatims that we have here, but we have pulled a few quotes directly from our interviews and the IDIs and the online bulletin board portions of the study. And so just to summarize, in that navy on the left, we have a peer that shared that it made them feel like their life experiences were really worth it, kind of highlighting or underscoring that sense of purpose that we were talking about earlier. It gave them this sense that they could offer hope to others that had been in that role. And then on the right, in that lighter blue, we have a quote that discusses that this individual didn't know that being a peer recovery coach was a thing. They didn't know that that was an option. And once they were made aware that that was something that they could get paid to do professionally through having their own experiences with peer recovery coaches when they themselves were in recovery, they knew that it was what they wanted to do. we really wanted to dive into the certification process here. And so you're going to see a couple of slides on these findings. We wanted to understand, was it difficult? Was it enjoyable? Was the curriculum challenging enough or too challenging? And what were all the opportunities kind of around becoming certified? And so overarchingly, participants were happy with the training curriculum. Many of them felt like it was encompassing enough that they learned the things that they needed to become a peer recovery coach. They found, again, overarchingly, that the process was mostly or very easy. And we have 2/3 here. And again, I'm going to put that disclaimer out there to please interpret these results through a qualitative lens, that that's not meant to be extrapolated, but that the majority of those we spoke to felt that the certification process was fairly easy. That's not to be confused with the curriculum being too easy. They all felt like the curriculum was just what they needed for the most part. However, we still have this outstanding pocket of individuals that felt like the process was difficult. And so we really wanted to dive into those areas to figure out where we could further support, how that could be tweaked or enhanced to make sure that it was more accessible or a little easier for those that were interested in becoming peer recovery coaches. And so what we identified were a few common themes among those that found it to have some level of difficulty. First and foremost, we heard that there was a lack of clarity about the required steps that it would take in order to become a peer recovery coach. I'm going to add another caveat here that throughout the entirety of these findings and throughout this study, we used the term peer recovery coach to encompass everyone, though we get into this a little later, but state-specific certification has individuals calling themselves lots of different titles. And sometimes it's not even a state-by-state difference. Sometimes it's just dependent on the environment that they're working in, the organization that they're working for. And so we'll hear peer recovery specialists, we'll hear certified peer recovery specialists, et cetera. And we found peer recovery coach to be the most all-encompassing for the individuals in this study. So that's the one that we'll utilize throughout. That being said, the lack of clarity about required steps for peer recovery coaches to obtain that certification was evident across all those that, or among all those that found the process somewhat difficult or very difficult. They mentioned that they would love to have some sort of checklist or someone guiding them through the process so that they knew what was to happen next and where they could find that information. We also found that some had difficulty finding classes or finding a space to be able to do the field work in. So they were ready to go, but they just weren't sure where they could find the space to do those next steps. We had some individuals experience anxiety about testing. And finally, finding the time to complete training. And though many recognized this was a work-life balance kind of situation, it still was a barrier in them completing the training that would be required to become a peer recovery coach. We found something else here that I believe Karen will talk about at the end as we discuss some implications for further research, that the test and the training content is perceived to be primarily in English. And so for those that are English as a second language speaker or who are monolingual, primarily Spanish speakers, they found a pretty large barrier here in that all of the training material is in English and all of the testing material is in English. So we even had a few peer recovery coaches state that they had individuals that were in recovery that were only Spanish speaking or primarily Spanish speaking that they thought would make great peer recovery coaches, that they couldn't recommend to move forward with this process because they wouldn't be able to take the test, being that it is in English. So we do see that there's an opportunity here to convert some testing material and training content into Spanish and potentially other languages. We just happened in this study to speak to those that were Spanish speaking. Great. So as I just mentioned, certification processes are set at a state level. They vary significantly. We learned that the trainings can be anywhere from a single 25-minute webinar that would then allow you to become certified all the way to 136 hours of class time. And fieldwork had a similar wide range, 200 to 900 hours of fieldwork. Again, because this is qualitative, this is not an exhaustive range. This is just among those that we spoke with. So it's quite possible that there are trainings or programs that require less or more than this range reports on. So we have a couple of verbatims here, some that mentioned that it was really easy and they took one webinar and they were done. And then we had some that said it took up to 4 years. It was really challenging for them to be able to earn those hours. Again, some of them are unpaid, some of them are lower paid. And so they were experiencing some work-life balance issues in this as well, in that they needed to be able to hold down other jobs while they were doing this. This being said, there are certainly opportunities to improve the certification process. So as we mentioned, kind of switching some of those, helping some of those non-English speakers or those that are English as a second language speakers to have the materials in their native language would be really helpful and expand opportunities for those that are not primarily English speaking. And then laying out that process really clearly. We had a lot of requests for some kind of checklist or step-by-step, a contact person that would help walk them through what was next. So they understood where to go from here, really simplifying the process. We also found the job opportunities after certification were really varied. So for those that had connections prior to becoming certified, which was the majority of those that we spoke with, finding a job was not difficult. In fact, many of them were volunteering or working in that recovery space in some sort of administrative position before someone at their place of employment recommended that they seek certification. And so they went through the process, they obtained certification, and then were offered a job at their location. For the few that we spoke with where this was not the case, it was much more difficult. They had a harder time knowing where to look and figuring out how to enter the workforce with this newfound certification that in many cases took quite a bit out of them, may have taken many hours to complete, or may have taken applying for grants or money out of their own pocket. So there's an opportunity there to kind of streamline that trajectory from getting certified into the workforce. We found that the peers we spoke with worked in a wide range of settings. So this included hospitals, emergency departments, primary care clinics, specialty addiction treatment programs, et cetera. They worked alongside a slew of different professionals as well, and teams of different sizes, as you can imagine. So for some peer recovery coaches that we spoke with, they were the only peer recovery coach on their care team. And for others, there were upwards of 30 on their care team. And so we found that their experiences in the workforce really differed based on who was on the care team and how well they felt understood by the rest of their team. Part of this is the supervisor. We got a lot of feedback that a supervisor that is well-trained in what a peer recovery coach does and really understands that role is so helpful in helping the peer recovery coach feel valued and in making sure they're utilized correctly at their organization. It was noted that supervisors that are in recovery themselves, though this wasn't, no recovery coaches indicated that this is required, that they would like to see this be required, but they did note that if their supervisors in recovery themselves, it sort of naturally happens that their supervisor has had their own lived experience. And so they're much more prepared to understand what the peer recovery coach does and the recovery journey. And so this helps to make sure that we are utilizing peer recovery coaches correctly and to the full potential within the spaces that they're designated to be in. Sadly, we did hear a couple instances where peer recovery coaches felt very misunderstood in their roles, and their supervisors or their care team were asking peer recovery coaches to do things that were outside the scope of the peer recovery coach role. Finally, we also note that peer recovery coaches feel somewhat disrespected by those outside of their organizations. And so this comes down to who they're interacting with, other professionals, beyond just those on their own care teams. Oftentimes peer recovery coaches can find themselves in the place where they're serving as the mouthpiece for those that are in recovery. And so they're interacting with law enforcement, with other clinicians, things of that nature on behalf of or alongside of the individual in recovery that they're supporting. And this is met, unfortunately, by other professionals with some level of stigma. And so peer recovery coaches are still trying to combat this stigma, where they feel that some professionals are looking at them as addicts first and professionals second. There were a few peer recovery coaches that noted that they were provided with some tools that helped them combat this by their employers. Some noted that even having an ID badge helped to kind of bridge that gap between, we're both professionals. It helped to equalize that playing field a little bit. But it looks like we still have a little way to go when it comes to that stigma. And again, overarchingly, I think the takeaway there was that peer recovery coaches were hoping for just better education for other professionals and for the general public about both opioid use disorder and peer recovery coaches and what they do. Peer recovery coaches had a really good understanding of their own roles. They felt that they really understood their own boundaries and what was within the scope of what they should and should not be doing. However, peer recovery coaches mention that their roles can be a little bit more flexible than, say, another clinicians could be, in that they can speak on their own lived experience a little bit more openly, or they can offer rides if needed to some of those that they're supporting, where they say a therapist or something like that might not be able to do those things. And the peer recovery coaches that we spoke with loved this. They loved being able to kind of bridge that gap again and make that connection with those that they were supporting. We also found that nearly all peer recovery coaches reported some type of burnout or compassion fatigue at some point in their career, which is unfortunate, but there were also lots of suggestions on how to improve this, such as hoping that employers in the future would offer some support when they reported that they were experiencing burnout. Here we have a nice little summation of some of what we were just saying. And again, for the interest of time, I'm not going to go into each of them individually here, though you'll all have access to this presentation. I think one of the key takeaways here is that we asked in this activity peer recovery coaches to bucket some functions of their role or some factors in their role into 3 buckets. This makes my job easier, this makes my job harder, or this is a neutral factor, doesn't help or hurt. And I think the real standout here is that everyone who participated in this activity felt that their own lived experience with recovery made their job easier. So potentially unsurprisingly, but still a little disappointingly, financial opportunities and career advancement seem to be a key area of opportunity for peer recovery coaches. Many reported low pay, many reporting between $13 and $15 an hour. And there were lots of concerns that it wasn't going to be enough to cover their basic needs if they were to stay in this role. There's also no clear upward mobility. So they weren't sure what happens after this phase of peer recovery coach. What's the promotional opportunity? With some identifying that their only solution to this might be to go back to school to become a licensed clinician, which changes their role and isn't necessarily what everyone wanted to do, as the verbatim shows. We certainly had to talk about the pandemic, being that this research was conducted throughout it. And again, potentially unsurprisingly, but the stress and isolation of the pandemic really took a toll on peer recovery coaches. Mostly it took a toll on those that they were supporting, in that many peer recovery coaches saw much greater needs among their peers. They saw relapse rates, overdose rates, and death rates increase. They also found new unprecedented challenges in terms of support. So some specific communities didn't have access to technology during this time, and all in-person meetings were canceled. So they weren't sure how to support anyone that had previously been been within the group of individuals that they were supporting, even if the peer recovery coach themselves had access to technology. So this caused a real hurdle in that, and a real imbalance in that we're seeing the increased rate and the increased need for support, and we were seeing decreased access in ways to support. So with those challenges, there was one, I'm so hesitant to call it a bright spot, but some noted that one small positive throughout the pandemic was that they were able to reach a larger audience. For those that had previously not worked for institutions or organizations that offered at-a-distance support, that became the new norm. And so they were able to expand that and offer it and reach some that they had never been able to reach before. And so peer recovery coaches see this continuing into the future, this increased at-a-distance support alongside of the much welcomed return to in-person support. They just really stress that there's more technology training needed if this is to remain true. And that's technology training for the peer recovery coaches themselves. Some would even like to see this filtered into the certification, the education at the very beginning, or ongoing technology training, and for those that they're supporting. And they would really like to see those that they're supporting have increased access to working devices if this is to continue. And finally, we have a little summation of what we talked about. This was an activity that was just a simple rating activity that was conducted among all those that participated in the online bulletin board portion of the study. We asked them to rate their overall confidence in their ability to do their jobs with no mention of the pandemic whatsoever. And as you can see, many rated themselves a 10, completely confident. They felt that they had all the tools they needed to succeed in their role. Though when we asked again at the end of the online bulletin board phase of the study about their confidence during the pandemic, we see a noticeable dip here in terms of how confident they felt throughout the pandemic. And so again, that kind of just underlines the earlier two slides, in that the pandemic has definitely caused some new challenges. And though I think we're all hopeful we're on the other side of that, we do see that at-a-distance support may continue. So there are certainly opportunities to enhance their ability to provide at-a-distance support. And with that, I will turn it back over to Karen for some conclusions and some next steps.
Aubrey, thank you so much. And I can see from the chat that a number of the findings are really resonating with people in the audience, which is really terrific to see and really reassuring. We heard clear messages from the study participants, both about how their high levels of satisfaction with their roles in helping others, but also opportunities to improve and strengthen the role and the workforce. And this is certainly going to be a part of our next phase of work in terms of understanding how, as a foundation, we can help contribute to these discussions. The findings raise a number of questions for us as we think about the next phase of the work in terms of the survey, as well as how we interact with grantees and hopefully with many of you in terms of both policy and practice improvements that can support this workforce. So among those questions, we want to think more about how healthcare organizations and other organizations who are hiring peers can educate their colleagues and staff about the role and the ways that these organizations can most effectively partner with peer recovery coaches to support recoveries. We want to explore further what employment policies are really needed to support peers during a transition into the workplace. We heard that for many of the peers, this may be a first job in quite a number of years and quite a long time, but ensuring they have access to healthcare, access to supports that they need for their own recovery particularly during such a significant transition is critical. We also heard a lot, as Aubrey described, in terms of the pluses and minuses of the current certification processes. So continuing to explore and ask questions about how to make the process really clear for people, how to perhaps expand the content of the training, particularly about specific recovery populations, such as pregnant and parenting people, to expand the content. And then most importantly, how do we bring peers themselves into that certification process, the training, content development, and delivery? Related to that, we also, Aubrey described the challenges we had in locating bilingual peers to speak particularly about working with Hispanic populations in communities around the country. And what I take away from that was certainly the need to think more broadly about how we support the recruitment and training of Spanish speaking, of bilingual, but more broadly bilingual and bicultural peers to be able to reach a broader population. We heard a lot about the financial concerns. And so as we think about the roles, we need to think about how we support the roles in terms of wages and benefits and job security, as well as opportunities for advancement. And then finally, one of the most striking to me was that how clearly the peers are such a valuable component of our ability to understand what's happening on the front lines of addressing the opioid crisis. And this couldn't be more clear, more relevant, given all of the headlines this morning in terms of the latest numbers of overdoses in the past year. So how do we engage these peers, not only to support them to do their work, but to make sure that we're getting this ongoing learning as we think about policy and practice? So that's some of the work for the foundation to continue to think about in the survey and our other work. And I hope that it helps generate thoughts and discussions amongst all of you as well. In terms of what we learned from peers, I do want to highlight an additional publication, which we also released this morning. We took the opportunity to interview 3 peers working on 3 different grant-funded projects that FORE is supporting at the moment. And an issue brief today is a Q&A with these 3 individuals: Chutin Arrow Everard Archer II, who is part of the IDEA Exchange at the University of Miami; Emily Hash, who's part of the health system in Tennessee and Virginia; and Tommy Trevino, who's part of the California Bridge Program at UC Davis in California. These 3 individuals were remarkable in sharing both their personal journey as well as their experiences with their roles, the roles they serve as peer recovery coaches. And I really encourage and hope that everyone will go to our website to read this brief on spotlighting the peer recovery coaches, as well as the report on the survey. So to continue our discussion now, I'm pleased to introduce Courtney Lavelle, partner and co-founder of Our Wellness Collective. Courtney is also a member of our National Scientific Advisory Council. And Courtney will be followed by Professor John Kelly, a professor of psychiatry at the Harvard Medical School and founder and director of the Recovery Research Institute. Courtney and John will each add to our discussions now with their reflections on the study findings and future directions. Courtney?
Thank you so much, Karen. Thank you for having me. I've gotten to be a part of this survey process from the back end forward, and I am so excited that this report has been released and that there's some really great information for us in this field to kind of pick apart and learn from and grow from. A little bit more about me, my background. I've been in recovery myself for the past 13 years. And when I entered recovery 13 years ago as a young adult, I had a lot of the wreckage that most of us do when we first come into recovery. I had a pretty spotty educational background. I had a criminal record, and I had no idea what I was going to do with my life and my future in my recovery. I was pretty fortunate enough to get an entry-level job with an addiction clinic and doing reception work, and that clinic sent me back to school. And I was able to become certified by the state as an addictions counselor. So I started my career working clinically as an addictions counselor. And, you know, I really loved that work. I think primarily because most of us in recovery can relate to this. We have this aptitude for helping others who have struggled the same way that we've struggled. We have this drive, this desire to give back. And doing clinical work provided that to me really early on. It gave me a way to help other people, friends, peers, individuals I could really relate to help support them in their healing process. And I also had to be incredibly mindful of having a felony record as a young adult that really limited my career options. So becoming an addictions counselor seemed like the only option for me. And I loved it. I thrived in that work, but I started pretty quickly to notice some gaps and some struggles in doing the work, primarily being that I had this wealth of lived experience and insight and knowledge that I couldn't share with my clients because of those different ethical boundaries that you have when you're working in a clinical capacity. When you're working as an addictions counselor, when you're working as a social worker, your role is not to share your personal information. And I would struggle immensely with this in supervision. I just wanted, sometimes the pull was there to just connect with somebody with that lived experience and to let them know that, yes, people have come before you and struggled in the same way and they have pulled through. So I struggled with this, having this, what I felt was an asset, having this experience, this wisdom, this insight that I couldn't share, but also all the gaps that there were in providing supports to individuals in treatment. Beyond the outpatient clinic that I worked in, there wasn't much support available to people. I worked in an urban setting that also serviced a very rural area. And if, you know, a few hours of outpatient treatment wasn't enough for you, the only other real place to get support beyond that was in maybe 12-step meetings. And if that didn't work for you, or if that you weren't connecting in those meetings, or it didn't jive for whatever reason, there was really nothing else out there. And I couldn't accept that. I really had a hard time with sending people home after clinical hours with no other support, no other contact. And I think that was probably about 8 or 9 years ago now that started my journey into this more macro level peer support workforce development career path. And, you know, I really found my calling there and my home there in doing this work, trying to provide another layer of support to individuals early in their recovery and trying to sustain their recovery, as well as uplifting and promoting our lived experience as an asset and helping create a whole other career path for individuals like myself, who maybe because of a lack of education, maybe because of a lack of employment history, or maybe because of criminal records, might struggle to find a good, healthy career option in other avenues. So I started doing this work. Can we advance the slide? I think about 4 years ago, I started doing our Wellness Collective. A partner of mine started this business. We wanted to try to expand and promote peer recovery coaches and advocates. We wanted to help get people trained and certified, and we wanted to really strengthen this new field. I mean, this was the answer for me. As a clinician who couldn't share my lived experience, I saw right away the value of incorporating these peer roles into both clinical settings, community-based settings, hospital settings, really anywhere that I could. I could see the value of having somebody who could be that role, who could share their lived experience, who could be inspiration, who could be support, and who could just walk alongside somebody on their journey. And I saw that, and I wanted to do whatever I could to help expand that and promote that. So we started doing training for individuals to become peers, training for clinical supervisors to learn how to provide appropriate supervision for peers. And we have seen so many of these challenges and these gaps identified in this report. I mean, as a coach myself, as a coach trainer, some of the things that we encounter are really a lack of supervision primarily. Peers out there trying to do this work, trying to learn to do this work, and just not getting enough supervision, or sometimes not getting the right kind of supervision. Often being provided supervision by individuals who are not necessarily peers themselves or have not gone through any training to really understand the role of a recovery coach or advocate. So that's a huge gap that we've seen. We also see just the role being misunderstood in various settings. Because of the flexibility of the peer role and its adaptability and being able to work in various settings, there's a lot of role confusion, sometimes with the peers themselves and often with their colleagues, often with clinical colleagues, often with supervisors. So we've been working very hard to try to resolve this, trying to help both the peers themselves get a solid understanding of their role, of their ethics, and the places that employ them, to also understand, the value of this role, to incorporate the role properly, and to understand what the role is not. And we've been doing a lot of training around this. And this specific part in the survey that I pulled out about training, I think is the biggest issue that we've seen, but it's also the biggest opportunity that we've encountered. I think the solution for some of these challenges lies in just better, more adequate training being provided on every level to the peers as they're learning to become peers, to the peers for ongoing education, for the supervisors providing supervision to these peers, and to the entire agencies and organizations that are implementing these services. If we can improve the training and the support all around, then I think a lot of these other challenges will be resolved. Next slide, please. So one of the things that we did at our Wellness Collective, when COVID hit, the pandemic hit, and we could no longer provide in-person training, we tried to be one of the early adapters to really convert and pivot to online training and rebuild all of our training, update all of our curriculum, and make something that could be accessible to everyone, especially in this time of pause that we were in last year, where we really had to take a step back and reassess what we were doing and try to find smarter ways to deliver the services, to deliver the trainings, and just to do what we were doing. So we created an entirely new training that was much more up-to-date curriculum. We included things on opioid use disorder and medication-assisted treatment at all levels of the training. And we made it all digitalized so that people could take training whenever it was convenient for them. I mean, a huge barrier, as we have seen in the report for this training, is just individuals being able to complete the training. A lot of times training is many days, 5 or more days in person, where you have to take time off of work, and you have to also generally pay a very large amount of money to go attend these trainings. So we wanted to try to make it so that it was more accessible. It wouldn't interfere with people's lives as much. It could be done at their own pace, and that it would meet all of the different learning competencies set by the ICNRC. As we discussed earlier, we heard from Aubrey that different states have different certifications, but by and large, if you're going to become certified as a recovery coach or peer, you're going to be meeting the ICNRC domains. And we made sure that we developed training that met these domains, met the knowledge, skills, and abilities that were needed in each domain, so that it didn't really matter what state you were in, what area of the world you were in, you were still being provided the same training with the same competencies in the same areas, to hopefully uplift the entire field to the same standard. So that even though you can, take a 25-minute webinar in one state, there's the option that you could have this really robust 46-hour training available to you that's much more affordable. So that's what we built and we implemented, and it's our contribution and our way of trying to help uplift the field as a whole. Next slide. Our goal really is to help streamline the process of becoming a recovery coach or a peer advocate. And it's also to help make it a better experience for the individual who is trying to find their way in life, trying to find their career, trying to go make it through that part of you, especially your early recovery, where you're rediscovering who you are and who you're going to be with all of these behavior changes that you've been able to accomplish. And how are you going to integrate all of that good stuff into your life moving forward and into possibly a whole career path? We want to make that much more, effective and smooth for those individuals who are seeking that. So we developed recovery training online. to hopefully become that one-stop shop for the training that you need, the supervision needs that you might need, support for your maybe employers or your colleagues to help better understand the role. I think if we can, as a whole, come together and start really streamlining the qualifications to do this work, it'll only advance the work that we're doing and prepare us as the coaches and the advocates ourselves to do our work. So I think I personally am really excited for our next round of surveys to dive a little bit deeper into some specific areas like supervision. But everything that we've experienced ourselves as trainers has been echoed in this report. And although there are some pretty substantial gaps still in the recovery coach and advocate field, I see far more opportunity than I do gaps and issues and challenges. There's just a lot of opportunity for growth and a lot of momentum behind it right now. Thank you, Karen.
Thank you, Courtney. John, please go ahead.
Great, thanks, Karen. Hopefully you can hear me okay?
Yes.
Fantastic. Delighted to be here with everybody. Just a fantastic presentation, set of presentations. Really honored to be here, part of the panel. Thank you for the invitation and opportunity. And thank you to FORE, the Foundation for Opioid Response Efforts, for leading this today and for putting it out there and for helping to facilitate the research that was beautifully presented this afternoon. That was very inspiring and very promising in my mind. I'll be brief, but I thought I would start by giving a little bit of context for where we've come in terms of our understanding of peers and peer recovery supports, and the value that we now know that peers and social factors play in recovery from a scientific as well as a theoretical perspective. You know, one of the things that I've been reflecting on, I'm a professor and clinical psychologist, professor in psychiatry, and I've been studying addiction treatment and recovery factors for about 30 years. You know, one of the things I've been reflecting on just in the last year or two is the war on drugs, because it's been 50 years since the declaration of the war on drugs back in 1970. And so I've been reflecting on, you know, kind of how far we've come and what have we learned in those 50 years, because we've learned a lot. And I wanted to take stock a little bit of where we've been, what we've learned, and why we are where we are now in terms of this focus on recovery support services, and the desperate need that we have for it. You know, it's interesting when we step back and we think about, you know, what we did not know 50 years ago and what we now know. Think about that for a second in terms of the causes of addiction, the impact of addiction in the brain. You know, our understanding of genetics and what a powerful role genetics play in terms of creating a susceptibility to addiction, just like many other complex illnesses. The fact that substance exposure affects the brain, it changes the brain. And these brain changes constitute what we know as addiction, both through processes of neuroadaptation and neurotoxicity. We've understood more about epidemiology and risk factors for addiction, broader psychosocial, economic, as well as individual risk factors for addiction. We've also learned about different effective treatments, and also that there are different pathways into and out of addiction. And that's given rise to many different types of new treatments, manualized psychosocial treatments, and potent and effective medications, particularly for opioid use disorder, which is saving lives every day. So all this is good news. One of the things I think we've learned that we don't know about, of course, that's one of the findings, is that we learn what we don't know and what we need to know, is that we've learned that the course to remission and the course to stable recovery for people with addiction, that's to say, people with severe substance use disorders, people that we typically see in specialty care settings and in recovery support service settings. We know that the course to remission can be a bumpy one. It can take many years for people to establish that first year of sustained remission. In fact, in adult studies of addiction patients, it takes roughly 8 years to get 1 year of sustained remission. Now, it can take 4 or 5 treatment episodes for people to achieve that remission in about 8 years, as I said, in adult clinical samples. So that's a big deal. That's a long time. Well, people are making progress during that time. They may get a few months of recovery and then relapse, get on the next occasion, 6 months of recovery and then relapse. People typically are getting longer and longer periods of remission before they achieve that 1 year of stable remission. Now, here's the other thing that we've learned, though, is that even after people achieve that first year of stable remission, it can take 4 to 5 years of continuous remission before the risk of meeting criteria for substance use disorder in the following year drops below 15%. Why 15%? Because 15% is the annual risk in the general population of meeting criteria for a substance use disorder. So in other words, to be no more likely than anyone else in the general population to meet criteria in the following year for substance use disorder, if you've already had it, takes 4 to 5 years of continuous remission. So people remain at elevated risk in those early years, even after they've made that big step of achieving that first year of full sustained remission. Now, the question here is this inexorable? Is this just part and parcel of the illness? Or is there something we can do about this to shorten the course, both in terms of the time it takes to get to remission and the time it takes to achieve more stable remission? In other words, to be no more likely than anybody else out there in the general population of meeting criteria in the following year for a substance use disorder. I think the answer is definitely yes. There's more that we can do to help people achieve remission sooner and achieve stable remission sooner. What are those? I think I liken this to a metaphor I often use when I give talks of a burning building. I think we've recognized that the building is on fire, and I liken this to the crisis of addiction. We recognize that the building is on fire and that we need to do something about it urgently. In this regard, we've done a good job. We have designed and implemented medications and stabilization procedures, detoxification procedures, which can stabilize life-threatening withdrawal and help people stabilize in those initial days and early weeks of recovery. We've done a good job there. Where we've not done such a good job is thereafter, is how do we actually, after the fire is out in the building, how do we provide people or the building with the building materials to be able to rebuild and refit the building? And also, very importantly, can we and do we, how do we provide the building permit that allows the building to begin? As I think Courtney had mentioned, that denial of a building permit by virtue of the fact that someone has a criminal record related to their drug use and alcohol use in the past means that they are prevented from getting a building permit that they can start to rebuild their lives. And this is something that's very crucially important from a legislative perspective to be able to look at and change so that we can help people earlier in the process to get a job, to get a loan, to get housing, which they're prevented from, oftentimes because of prior convictions related to their drug use. So very importantly, the building materials, the building permits. And this is where the building materials in particular, the social aspects of that become so important. People need a social network around them of both the people with lived experience as well as other people. But the people with lived experience, they can act as role models, they can provide accountability, they can provide empathy, authenticity, so many of the things that people need to be able to reduce their own sense of shame and stigma around having experienced a substance use disorder. So the value of peers and peer recovery coaches, I think, are more potent than ever before. we've known for a long time with the research conducted on mutual help organizations, which are the oldest form of peer support for addiction, that have been around for hundreds of years, and most notably in the modern era through AA and other 12-step organizations, but now through many other different types of mutual help organizations and peer support structures and infrastructure that have emerged and grown over the last 20 to 30 years. These have taken the form of recovery coaches, peer recovery support specialists in recovery community centers and recovery community organizations that have emerged and grown all over the country and all over the world. This is, I think, fantastic news, because it's helping to really put a face and a voice on recovery, to help people dismantle the stereotypes, disabuse people of the kinds of beliefs that they may hold around what recovery looks like, and that people actually get into recovery, contribute to society, achieve, vote, pay taxes like anybody else, and contribute in civic ways to volunteerism and many other aspects. This is the good news, and this is what is emerging. I think what's really so promising about the results we heard today is that it's really just uncovering the nature of the challenges facing peers as they enter the workforce in this very crucial role, I think, which is only going to expand. As other fields have emerged over the last 50 years, including addiction counseling, as I think Courtney was mentioning, there's a kind of a tension between the grassroots of the movement and then the certification and professionalization, standardization, credentialing, and so on that comes along with it. I think for the from the public's perspective, they want to see standardization. They want to know what they're getting when a certain person identifies themselves as a certified peer specialist or as a recovery coach. Does that actually mean something? Is that standardized? And does that mean something right across the country, as opposed to in idiosyncratic ways, in different ways in different states, where the standards differ, as Courtney nicely pointed out, in terms of the training requirements and other training requirements. So I think this is going to be the challenge. But what was really nice about this preliminary work, this phase 1 work that was highlighted by Aubrey, was the kind of look under the hood in understanding of both the positive experiences as well as the challenges facing the peer recovery workforce, that we can then hopefully begin to ask the right questions and address them effectively to be able to increase the capacity, desirability of getting into these positions. And thinking through about their value, demonstrating their value from a research standpoint, when we supply recovery coaches and other peer recovery support specialists in different service settings where we can help people attain and sustain recovery. This includes community-based services as well as hospital services. I work at Mass General Hospital, for example. We employ peer recovery support specialists, recovery coaches, as part of our clinical team. And we've actually published data now showing a benefit of including recovery coaches as part of the clinical team to attract and engage people who might not otherwise be attracted and engaged by personnel in a general medical setting, and to follow them. As was pointed out, one of the great assets beyond lived experience is the flexibility that recovery coaching can provide, that cannot be provided by other kinds of clinical resources. And I think this is a major asset and what we need to match the undulating course of the illness and the needs of people. The needs of people in recovery, particularly early recovery, don't stop at 5 p.m. They go into the evenings and especially the weekends and times when there's a less structured time. And so people really need that flexible support. And this is something that peer recovery support specialists and recovery coaches can provide, as well as the time flexibility, is the location flexibility, being able to meet people in different venues, different places, coffee shops, restaurants, even on the corner of a street to talk, to support, and to encourage. And this is so important, I think so valuable. So I'm really looking forward to phase 2 results here. I'll end my remarks there, but I can tell you I'm very optimistic that the next 50 years, when we think about the last 50 years of what we've learned in terms of the etiology and epidemiology and the typology and the phenomenology and the clinical treatment, over the next 50 years, we're going to learn a lot about recovery, because that library, as has been pointed out by Tom Coderre, is virtually empty in terms of our understanding, both theoretically and empirically, in terms of understanding how recovery works, how people achieve and sustain long-term remission and stable remission, what happens to them in their lives, and can we provide a better conceptual understanding of that and more empirical support for the kinds of things that people need to attain and sustain long-term stable remission and quality of life. So I think that's where we're going to go. We are moving there. I'm really happy that the current administration has appropriated 10% of the funding of that $14 billion appropriation to recovery support services. I think it could be even higher, more like 30%. Could be dedicated, but I'm glad to see that at least a segment of that is dedicated to recovery support services. So with that, I will say thank you, everybody. I look forward to the Q&A and discussion. Thanks, everybody. Thanks, Karen.
John, thank you so much. And John and Courtney, thank you both for such peer-centered, recovery-centered remarks. Really adds to our window of an understanding of the role and the opportunities. I believe we are all on camera, or Ken is getting us all on camera. We have time for maybe getting to 2 or 3 questions if I ask our panelists to keep answers on the brief side. And we will, as always, also follow up with a document to provide responses in writing to some additional questions. But I do thank all the participants for adding questions to the list. John, maybe just to stay with you for a moment, we had a question about payment and reimbursement models and understanding that that's a huge issue, big barrier to expanding the workforce. But are there any models or examples where it's being done well in terms of supporting the peer workforce?
It's a great question. I'm sure there are. We have our own model here at Mass General Hospital where I work, which people are paid just as part of the regular clinical services. They are a peer with lived experience, but they operate and function as an equal member of our team, of our addiction consult and liaison team, which addresses substance use disorder. And they're an equal valued member. At least that's the intention. That may not always happen, of course, may not experience it like that. We, I think these data that were presented today kind of demonstrate some of the feelings of some of the recovery coaches around the country, that they may be seen as second-class citizens. Yeah, in terms of payment models, I'm sure there are. I think ours is just, it's a straightforward payment model that is paid as part of our reimbursement infrastructure.
Thanks, John. Courtney, questions about the job satisfaction. And one of our audience members said that they have heard about a lot of turnover in the role and seeing some of the results related to challenges or in different work environments and job satisfaction. And that can certainly drive turnover. In addition to what we heard from in the study about supervisors and environments, so there are a couple of things you'd suggest that help bolster that job satisfaction and potentially keep people in the roles and the jobs longer?
Yeah, I think what we see very often is just a lack of understanding of the role and clarity on the role responsibilities, depending on the setting. So if there's ways to improve that awareness of the role for the recovery coach themselves and for their employer, that helps. Supervision, if you can't receive enough supervision within your place of employment, there are a lot of emerging group settings. There's Facebook groups for group supervision for recovery coaches, there's support groups. If anyone wants to be connected to those specifically, I put my email in the chat. I would love to connect people. If it's not built, we build it. But it's a lack of support and understanding of the role, I think, that leads to this burnout that we're seeing. When peers are being asked to do things outside of their role, it's really stressful and it's hard.
Thank you. Thanks, Courtney. And Robin, we had a question about what we heard in terms of how peers learned about certification and training.
Yeah, so it actually seemed like in most cases, and again, keeping in mind this is a qualitative study, but the reality was in most cases, it seemed like a lot of the peers were already connected with the place they ended up ultimately working at. And that was the place where they heard about the certification. They were encouraged, you know, they were perhaps there as volunteers or they were there as recoveries, and they were given some information and encouraged to go down that path. And that was sort of one of the things that Aubrey mentioned is that was one of the reasons why they were often able to get a job right after, was because they went through that path, and it was paid for also by the place where they were already connected with. And that seemed to be common. There were some people that had heard about it in other contexts, but it seemed to be sort of more word of mouth. We did not get the sense that any of the peers were kind of doing online research to try to find where might be a place they wanted to be getting certification from.
Great, thank you, Robin. And I should have introduced Robin. Robin is led the team at SSRS in conducting the study. Courtney, there were questions about, given the challenges and the variation in state to state certification, do you see that we're heading for any sort of national certification or national standards around this?
Yes, so there's definitely groups right now that are working, trying to advocate for some national certifications. The Certified Recovery Peer Specialist is recognized in many states. Again, the ICNRC is that's the entity that has the peer exam, which most states require for certification. So their peer competencies are really the standard. If we can get everyone to agree to meeting those standards for training, then it'll start to streamline it across the country. But I think that is absolutely where we're heading, hopefully.
John, you also kind of referenced the importance of standards in terms of recoveries, knowing what the role is and understanding the role. I wondered if you wanted to add to comments on that perspective.
Yeah, no, I think that's very important, isn't it? You know, because I can tell you as a psychologist, you know, they're so protective over that title, as I'm sure many professions are. You can't call yourself a lawyer or a psychologist unless you have, and you know, they'll be after you if you put yourself out there as one, because they have these standards, and it's a matter of public trust, isn't it, and public safety, that people who have a particular title, that the public knows what that means and what that confers and conveys. And so for credibility purposes, legitimacy and public trust, I think it's important to have standardization. It can really benefit from that angle. So I think it's inevitable to move in that direction, and I'm pleased that it's moving in that direction. We'll see how quickly that happens.
Thank you all so much. I see that we are just past 4:30, so we're at the end of what's been a really amazing webinar for us. Thank you so much for sharing your time and expertise with us, with the foundation, and with all of the participants on the webinar today. Just to again remind everyone, the reports that were mentioned, the issue brief, as well as the issue brief about the peers, are all on our website, which is forefdn.org. There was a question about how the study was funded. It was funded directly by the foundation. We're a grant-making foundation, and we directly supported this project. And we are happy to continue to engage and to take more questions and interact with many of you as we continue to do this work. Please do complete the survey right after the Zoom, because that will also include a question about what some related topics might be that you would suggest we look at in the future. Again, a big thanks to Tom Coderre, to Aubrey Kaufman, John Kelly, Courtney Lavelle, Robin Rappaport, and to my team at FORE for a terrific afternoon. Thank you all. Stay safe.